Certainly, although this is an everything must go moment in healthcare spending where cost seems to be no object right away when you add everything, if we're going to make any progress in what are various experimental and somewhat more developed efforts to turn around and bend a cost curve which seems to be going up despite either the best or the worst efforts of the current legislators, one provision which has gotten less attention is what type of information, incentives, and then adjustments to that might begin to more subtly adjust the ways in which healthcare is delivered so that it's both more effective, more efficient, and delivers the value that we say we're seeking.
And why survey patients about physicians? Patients are really the key source, in some cases the only source of information on some things. They're a very important source of information on physician-patient communication, trust, advice on prevention, self-help, shared decision-making, care coordination. These dimensions are not just satisfaction-related dimensions, although they certainly have a lot to do with satisfaction, and satisfaction is not a trivial consideration in a trillion-dollar industry. But they also, there's quite a lot of evidence and increasing evidence that that what patients can tell you about doctors really relates to clinical outcomes. I should say there are no silver bullets on this thing. You've seen the passive websites, the consumer websites, where you can see all kinds of problems with sample size, et cetera. And the health plans that have put these things up on their website, oh, come rate your doctor, nobody goes. They just, if they get 3 patients rating a doctor, they've really struck it rich. Handouts in physician offices, there are real problems with manipulation and credibility of the data. When it really counts, it's fine if they want to hand it out for their own quality improvement purposes, but if it's high stakes for paper performance and public reporting, it's really problematic for them to hand the questionnaires out. Email surveys, of course, are a great way to go. We'd like to go that route. I don't think we'll ever pick up adequate sample that way, but we could pick up a lot and cut the cost significantly. Unfortunately, neither the plans nor the doctors nor the medical groups, for the most part, have email addresses. Amazingly, that's someplace we should be going with meaningful use in the HIT arena. They ought to have email addresses.
And here's a little bit of information on the methodology. Again, we're adjusting for health status, although there are issues there, and our team would be happy to talk to people who are interested in how one does that. We rank beneficiaries from 1 to 100 on actual expenditures within their similar health status groups. I think there were, 25, 26 groups. And then we looked at the physicians with respect to how the expensiveness of their patients sorted out among physicians in each specialty in each geographic area. And then we're measuring how expensive a physician's patients are compared to the patients of other physicians in the same specialty and area.
So why would we want to add physician performance information to the healthcare toolkit when you've got all these other wonderful things that people have imagined? Well, that's the problem. We're kind of imagining this, these integrated systems are going to work wonderfully. Well, that's not what we have in the delivery system, and in a lot of cases it may matter what a particular individual physician is doing rather than thinking there's that, fully seamless team of care where they really know exactly what's going on and just tell everybody else what to do and everybody performs accordingly. So the question really is, as we've seen in some of the earlier discussions, who's making many of the important healthcare decisions which feed into a larger approach to care, and where does that variation or the variance come from?
If you each had to pick something that would have an impact on cost from your vantage points, what might we have done in this bill that would have that effect?
Where we're going in the wrong direction is this is primarily an effort to further hide price tags rather than make them more vivid, and despite all this talk about other performance information. So we're suppressing on one end what might make a lot of different individuals care about what's going on in their care, and that's running in a different direction. We're also I think diluting what needs to be emphasized, which is a broader structure of, accountability across the board for everyone. And we're leaning too far beyond the certain basic minimums towards standardization. This is leading to a much more centralized process, which, because of all the demands being placed upon it, will ultimately choke of its own weight. This is too complex, too hard to think that with just the biggest enough right committee and the ultimate decision makers, if you look at all the provisions in here where the secretary will decide or some other body to be created will do, these are just pretensions that this is all going to be worked out magically by writing just the right regs and have it all done through the usual bureaucratic process. This needs to be handed into more parties' hands to do that discovery process, and I think we're still pretending that if it's just standardized and centralized enough, we've got it right this time, and we're going to miss the mark.